so glad that to be here in Diani. It's not easy to speak after your mentor. Dr. Muli has dissected it well. He has kept time, so I'm going to make sure we keep up with this. So I think we are good to go, Tim. Okay. All right. So is it on here? All right. Great. So anatomically, from here, how about this? Can I have, I'll just pick my pointer. Yeah. I'll just pick my pointer right here. Yeah. Sorry. Yes, I have a video. Okay, good. So we are good to go. Thank you. So my topic is simple. Today, I'm just going to show you how to clean and shape the root canal anatomically. Every part of the root canal has to be shaped in a different way. There is no way you can shape the apex same as the coronal option. So today, we are going to learn about that. And in rhyme with our theme, advancing excellence in dentistry. And Dr. Muli has done it well. You have to be ethical, like the question he posed. Are you going to extract the tooth when the patient tells you extract? So I'm going to show you when do you extract and not extract. And last July, there was a theme of evolving endodontics in Manila. For them, they were advancing dentistry in root canals. And I was asked to speak on how to advance in irrigation. In this conference, I'm also going to show you how to advance in instrumentation. So that's why, and we met with many professionals from all over the world, like the president of the American Board of Endodontics. I asked them what they're doing in the US. And also, I'm here to also bring what's at the forefront of discovery, even in Kenya. I'm so proud to be in part of this region because my aim is to get what's at the front in endo. We release it to you, then it's up to you to take it or stay 10 years back. But of course, you are intelligent people. Like Dr. Muli said, you've got to go with what is current. And later on, I was also extended an invitation to the College of Dentistry in Manila. That was my alma mater, where I advanced the residents, the postgraduate students, on how to retrieve instruments minimally. So this was a lecture, again, 2 months ago in Manila. And today we are going to push you how to also advance in instrumentation. And also here in Kenya, just in case you want to have a package of how to advance excellence in dentistry with a series of courses we do offer here at Dental Aptitude College. Endodontics, we offer orthodontics, and we offer also restorative dentistry, photography, and also we do implants. And for your dental assistants, we do offer the dental assisting program so that when you're advancing in implants, imagine you leaving behind your assistant who is going to contaminate the implant, is going to fail. So we are not leaving them behind. And I'm so happy also this afternoon to listen to Dr. Akbar from Texas. We met yesterday. He's running a very serious program in the US, in Texas, on dental assisting. And he'll be speaking to us, I think, at 4:30 p.m. today. I just asked him what he's doing in the US. And actually, he's advancing the dentists with assistants merging together. So your success rate is higher. In October, also, we had intensive training with Dr. Yoshi. Many of you know he's the master of instrument removal in the whole world. And he taught me how to retreat, 2-day course. And I just thought maybe we are also busy. We have launched this one also in Kenya. And in November next month, we have a date, 21st and 22nd. You can choose which group, where I'm going to teach you the skills he taught me, and we are going to pass to you so you can also advance excellence in retreatment, because we believe every tooth has a second chance. Do not remove it. Removal is the last option. You can retreat. So this is an intensive one-day program we are going to show you. Currently, 98% of my patients are retreatment. Rarely do I get fresh case. And I don't want to be like Dr. Yoshi, whose waiting time is 10 months before a patient gets a booking. Recently, I've had a lot of problems because my waiting time is becoming larger. And I just thought, why mount a course where everybody can do this? So I'm encouraging you, if you want to save the tooth, you can join this program to help me reduce my waiting period. And so it will be, you can choose a Friday, you can choose a Saturday, and then we are going to have time together just to do this. And what next? What do I do? I also volunteer at Olmlaika. Many of you have gone there. Last April, KDA went there during the World Oral Health, and you did an amazing job. Many of you have been there. I encourage you to go and volunteer in the Masai Mara, and you'll get reward. And this is a picture which was shared by my colleague, Dr. Rotich. This one right here, this patient was just waiting for somebody to go there. I don't know how many months it got here, but it broke. It broke, then fractured, then started tilting, and then perio issues came in. And then the patient was just waiting. In the bush, this was in Samburu. Once in a while, you can join the caravan to go to Samburu and other parts where there's no dentist, and you'll find interesting cases. People are waiting for you to just help. You don't get a salary, but it's good to give back to society like many of you are doing. So I encourage you to do that, and you'll be blessed. Last April, when I was going there, I happened to book the same date with Dr. Lungo, and we did amazing work there. Dr. Lungo, thank you for helping me during that day. And many of you have been there. I'm not just mentioning Dr. Lungo alone, but there are so many of you who have gone there. And you can take a trip to the Mara. Just if you have a fan of bushes and all that, the clinic has everything except implants. So you can do any program except dental implants. You'll meet not only Dr. Lungo, a Kenyan, and me, but you'll meet dentists from the whole over the world, Israel, Canada, US, and etc. That time, I also happened to be just going down there between the border of Kenya and Tanzania, Masai Mara and Serengeti, and I was able to witness from afar the wild beast migration. This one was so good. I've not done this, I've just seen it natural world. And I zoomed how these wild beasts are advancing excellence in crossing the Sandy River. So how about you? Are you going to advance excellence in crossing to the digital world of endodontics or not? And they went. The Sandy River is in those bushes, and there are crocodiles. How they're going to advance their skills over the other side. This is Kenya, the other side is Tanzania. But there is a catch in between. So this is in line with our theme today. And we have all equipment and technology and even apex locators. We were able to do a lot of procedures here, and we got excellent results even in the bush. This is at Masai Mara, just apex locator and radiographs, and then you have excellent treatment. So you can come and make a difference. It's up to you. We need at least, it's not my organization, by the way, but it's a volunteering global organization. I'm just here to pass on the message to some of you who want to volunteer. At the same time, what I do, I also volunteer at the University of Nairobi, where I'm giving lectures in endodontics. Yeah. So once in a while, when I have a group of young doctors coming to train fourth year, I give them all lectures in endodontics. But today, let's see how to advance in dentistry. This is evidence-based. In case there is an equipment you're familiar with, I'm not going to promote, but I'm just going to show you what I use to achieve excellence in dentistry. So I have no conflict of interest. 1925, this is 2025, 100 years ago. This researcher was the first one to check the anatomy of root canal. And then 2018, we have Batucci Vasani, who came and did a micro CT scan and found out that the root canal, as you can see, is a complex anatomy. and made of multiplanar curves and anastomosis. And to achieve the objective of instrumentation, you have to really know your anatomy. It's not about opening the tooth, putting in the file, but you must know which part are you instrumenting at the same time. Your task is simple. Please remove the biofilm. If you leave the biofilm, even if you have a good post-op radiograph, perfect working length, but the biofilm is there, you are going to have failure in root canals. And in 2007 and 15, there have been changes in metallurgy of what the files, and this has empowered dentists worldwide to deliver predictable results. And these are some of the files that have been invented by Style Italiano Endodontics. This is 2025, just like you have iPhone 19 or I don't know, 20. This is 2025 files, which are highly flexible, and they are able to manage curved canals and complicated canals without breakage. Because ever since everybody studied root canal, they're afraid of fracture. So these are heat-treated files that can help you manage complicated and simple cases in root canals. So we're going to talk about them just in a short while. I have this question every day on my inbox: which files do I use? I don't tell them the brand, but when you buy, look for a file that's highly flexible. And nowadays we have what you call austenite and martensite files. And way back in dental school, I am happy to, my professor is here, Prof. Kitsumbi, taught us austenite and martensite. And I didn't know at that time what martensite means until I'll show you how a martensite file behaves in a root canal. So these files, when you use them in a curved canal, they take the body temperature of the patient and they curve according to the anatomy without stretching, without breaking. So, and when you take it back to the autoclave, this file is going to go back to factory settings. When you pour hot water, this is what happens in an autoclave. So it goes back, the atoms rearrange itself. So this is a martensite file. So if a canal is curved, it takes the body temperature and curves according to the anatomy. So it's not undergoing torsional fatigue like any other file that's NITI, but not martensitic. All files are NITI, but they're not martensitic. If you know your file is NITI, get it out and bend it. Check whether it's going to spring back. If it springs back, it's not martensite. If it remains curved, that means it's martensite. In a complex curved canal, it's going to take the shape of the patient's root canal and then instrument without breakage. Now, today we're going to master anatomically adaptive files that can maintain structural integrity, and also they will help you simplify the root canal treatment protocol. And your task is against biofilm, the bacteria inside the root canal. And we have two sets of files, one for all roots, that's regular canals, and another one for bigger canals. So today we learned that there's regular canals, large canals, and have you heard of XL? Just like you go to a shop and your size is medium, small, or XL. Which file do you use for the XL files? So they adapt to complex and simple canals. And even in bypassing ledge, in our retreatment course, we are going to show you how to manage and bypass a ledge. And these files can be pre-curved. For example, let me start with this case I got for referral. It's a tooth number 21 and completely sclerosed. We took x-rays and surely you cannot see anything. There is no canal. Other adjacent tooth teeth have got radiolucencies consistent with the root canal, but this tooth has no canal. Now, I am supposed to perform a root canal because the patient is in pain. So what did I do? I took CBCT, there was no root canal. I took apical radiograph, there is no root canal. So what do I have? The knowledge of anatomy. Where do you penetrate the entry point? Very important. It's a simple, anterior should be simple, but you must know the anatomy. Just above the cingulum, with the microscope, I'm able to penetrate and look for what you call a dentine map. Dentine map is the dark trail left by the nerves. The nerves were lying there. So under the microscope, I'm able to pinpoint the dentine map, and then I'm able to do the access cavity. What do I do with the access cavity? I start by mechanical preparation, go to file number 2025, and I'm done with the root canal at the correct working length. This canal has been prepared by metastatic files, which minimize distraction of tooth. Imagine this final size is 25, taper 5%. So it's not enlarging the root canal. So today I'm going to simplify your root canal, size 20, 25. When you get tucked back, you're done. But I'm also going to show you how to manage bigger canals. So the endomotor that I used has an inbuilt apex locator. When you're managing sclerosis, you risk perforation. To minimize perforation, you have to rely on an apex locator. When you're thinning towards the wall, the apex locator will show you that you're thinning out and then perforate. So I have to consistently attach my endomotor on the file clip so that I monitor, am I thinning the wall? So get back, or I continue moving apically. So this is another thing that helped me, if you ask me, how did you manage? Because in most sclerosis, you are going to dig, create a ledge, transport the canal, perforate. So apex locator will give you readings that you are in the right track, or when you're just at the orifice and the apex locator is showing you are exiting. So I stop going that direction and come back centrally. So that's how I've used. And then I did orifice opening, preserving the pericervical dentine. It is 6 millimeters below the orifice plus 4 millimeters above the orifice, a total of 10. That is the strength of the tooth. So internationally, we are supposed to do orifice opening 6 millimeters down the root canal. And this file has been designed to cut only 6 millimeters of the root canal. If you start pushing it deeper, it will stop cutting. Why? There is no blade beyond 6 millimeters. So you are sure you have finished the task of orifice opening. Why are you spending so much time on orifice opening? Yet you're supposed to go only 6 millimeters. So you have a guide. In this case, I loaded the orifice opener 6 millimeters down that sclerosed tooth, and then I monitored how the files is going to disappear. So this is the orifice opener under the microscope, and I am monitoring the file disappear below the orifice. So you have to stop when the blades disappear. And this way, you are preserving the pericervical dentine. Most of us may not know this trick, but you just know you are done with orifice opening when the files have disappeared. So finally, this file has disappeared. I can no longer see the cutting blades. So I'm able to go to the next stage. What's the next stage in root canal? After access, after orifice opening, you take working length. Never do working length without orifice opening. You haven't opened the door for the file for working length to go. So that's why some of us are struggling with root canal from beginning to the end. Open the door and then get down to the apex doing working length. So my next is to get a number 10 file and then go down to the apex. So I get a file clip, and then in the same tooth, I am able to go down on my apex locator. Some people ask me, what's the reading? Is it 0, 0? No, 0.5. So at 0.5 millimeters, I'm waiting for this. So always go beyond to get the frequency outside. We call it the segmental canal. Now today you learn there are two canals, dentinal canal, segmental canal. Segmental canal is where Dr. Muli works perfect. There's a lot of infection there. Just outside the apical constriction, that is where the perioendo lesions communicate. So you have to go to the segmental canal and then pull the file back until it stops in the dentinal canal. The junction between segmental canal and dentinal canal is called the apical constriction. It's 0.5 millimeters short of the anatomic apex. So I removed the file at 0.5 and measured. It was just 25 millimeters. Now what next? I get hand files, create what you call patency. So you've got access, you've got orifice opener, you have got working length. Next, hand files. some question I ask, so we have rotary, do we need find hand files anymore? No, we will never get out of hand files, at least up to 15. So you create what you call a reproducible manual glide path using hand files. After that, you get a transition file. Between the hand and the rotary files, you have a transition file called the glide path file, mechanical glide path file. So this is TEPA 3%, and hand files are TEPA 2%. So you are transitioning from TEPA 2 to TEPA 3, so the file does not break. Why in my practice I receive so many cases of broken files is I ask one question: do you have a transition file? Say no. What do? I get from working length to the first rotary file, then it broke. You have to have a mediator. The second last file, I'm showing you simple, practical way, is the yellow. The yellow has variable taper. The taper at the tip is 4%, picking up the 3% from the transition file. It picks 4%, middle 5%, and then 6% taper. So you are varying the taper because you are going to minimize risk of fracture. A file that has consistent taper throughout is going to break because there is no minimization, there's no distribution of stress in different parts of the root canal. So that is what you are going to do. And in this case, it was severely curved, and I was able to manage it it was referred to me, and then I was able to negotiate. So my colleague started, got a ledge here, and then I picked up with the Martenside file, variable taper, cleaning the tip with 4%, the middle with 5%, and the coronal with 6%, just in one file. So I was able to go and obturate this tooth. And then you have to preserve the dentine. The last file in this sequence, as I wind up my lecture, is just the red file, number 25. So you get number 25, it has 5% taper, and then you go down, prepare the canal for obturation. And once you've done your cleaning and shaping, for sure, you'll have clean canals like in this case, and it's the time to load calcium hydroxide. In retreatment case, it's good to have the medicament work for you because we are not perfect. So sometimes when you have cleaned enough, you'll notice MB2 is joining if your calcium hydroxide goes through the other one. If it doesn't come out, then it's just on its own. So after that, you stop at 25. So that's how endo is simple. Access, working length, transition file, beforehand, number 15, number 20, and then 25. But you only stop when you have tack back. There's something called tack back. Today, you are going to learn about two types of tack back. The flutes must be clean. This last file, number 25, when you remove it, check. This is a simple, internationally recognized method to check whether your root canal is clean. If your last file comes out without debris, your root canal is not clean. Are we there? But if your last file comes out, so you have to move to a bigger file to get the debris, the biofilm. But wait, if you remove the root canal, your file, and you see debris, the flutes are white, okay? It's coming out with something. It means your last file has printed its impression in sound dentine. So you've scratched biofilms out, and then you are going to have success. Another way is tack back. The last file should have tack back. Then you stop there. Now, what happens if the flutes are clean? I don't have scooped the biofilm. You go to the bigger files. And the bigger files are what? This accessory kit. It has only 3 files, 35, 45, and 60. For the first time in the world, we have a rotary file, 60. But it only cuts apical 3 millimeters because the whole blade is smooth. It only has cutting blades down, so you don't destroy the tooth. Now, this is optional if your canal has no tack back at 25 or your blades are not coated with biofilm. So you have to move. So you get a hand file and then insert it into the root canal, check whether it has tack back, then stop, obturate. If you don't have tack back, then you move. Because we are supposed to go with removal of biofilms, because there are a lot of interactions in the root canal system. And the most critical microorganism we know is E. faecalis, being present in even failed root canals, and it has persistent even after transition. Do you know that we don't clean 40% of our root canals? So that's scooping of the debris at the apex will help your irrigants go inside and clean and remove the bacteria that is available in the root canal. So we have to dissolve the tissues, we have to flush out debris, and then we have to eliminate all the microorganisms. So this accessory cater said it is, you take 35 only when you don't have tack back at 25, and you go to 40, so you stop at 35 if you have the debris with you, okay? And then only go to 45 if you have what? No debris at 35, and then go to 60 only when you don't have debris on 45. And then to finish this lecture, I want to show you 3 cases that I did. So this one is a Bertuzzi type 2, also referred to me. My colleague could not go down, so I was able to instrument with a 45. Why? 35 was not having the debris with me. And then there's another case whereby the 45 was not having debris with me. So in that case, I have to go to 60. And this was a retreatment case which I was referred by a maxillofacial surgeon to prepare the patient for surgery. And look at this lesion, it's so massive. So I went, because 35 did not have tack back, no debris. I went to 45, no tack back. So, and in 6 months when the patient came for review, actually the lesion is just shrinking. Because the patient came back, I asked him, how did the surgery go? He said, no, you know what, after you finished, the swelling disappeared. There's no pain. So I didn't go for the surgery. Oh, but you're supposed to go, you have my letter. So I'm healed. So I had to write nicely to the maxillofacial surgeon, the patient has radiographic healing, okay? So just like many of you are doing amazing things, I saw maxillofacial surgeons, reconstructing, stab wounds and all that. All of you are doing amazing, perio, everything, implantology. So here I get also satisfaction when I see such healing as an endodontist. And lastly, 60, if the 45 does not have debris. For example, look at this file. Look at this canal. Can 25 have tack back? No. Can 35? No. So you go all the way. And I obturated with MTA. Any file whose diameter is above 70, the recommendation is you pack MTA, 4 millimeters, because Garapacha is highly contaminable. I'm getting the treatments of anterior teeth. My colleagues did perfect working length, but there's failure. So GP is highly contaminable. So you have to pack MTA either throughout, the way I did, or 4 millimeters, then you're done. Lastly, what else? Oh, in pediatrics, those of us who are the pediatric dentists, of course, we have pedophiles for you, just 20, 25. And I tried this on my daughter. She's 9 years old. I was surprised. I woke up and the baby has swelling in a dentist's house. So, my goodness. So I took pre-op. Then I remember 2 years ago, I did a filling. Maybe she didn't brush well. Now, infection has got in. So she's the one lying, and my 6-year-old daughter came to help and pose for a photo. And my 12-year-old son is the one taking the photo. He's not in the photo. Yeah. So I dared myself. I've taught people that root canal can be done in one visit. I did swollen jaw in one visit. So I did this zinc oxide packed, no working length radiograph. I use an accurate apex locator, even in pediatric teeth. So this apex locator, look at this root. It's longer here. If you use files, you'll go down here. But if you use apex locator, look, it's resorbed. Have you ever extracted pediatric teeth? It's longer, but when you look at the furcation area, actually the portal of exit is not here. It is there. So that's how to do difference in pediatric teeth. So I dare do in one visit, augmentin prescribed, and then within 3 days, swelling gone. I keep checking on her, are you swollen? And my little daughter keeps telling her, oh, you see, we will go do another root canal. If you don't brush, I'll assist you again. So my youngest 6-year-old wants to be a dentist because she's always there when I have a family member being treated. Now, lastly, these files are in different lengths. This is a case which was referred to me. The dentist couldn't go to the end because for the first time in my life, I got a tooth that is a molar with 31 millimeter length. Now, in your practice, you must have some files that are 35 because you don't know which case will be longer. Most of us procure 25, which is okay. So have many 25 millimeter because average teeth length around 25. But have a few files for extreme cases. In this case, palatal roots, and nowadays, Dr. Muli talked of AI. It's difficult for me to tell the patient you have infection here. All of you guys are learned. You can see there's an infection somewhere. Can you see? But tell the patient, can you see there's some blackness? We call it radiolucency. And my patient told me, oh, I can see it up there. And I told, no, that is normal. It's called the sinus. Okay, but now with AI, just like what Dr. Muli, my mentor, did, I have different mentors, by the way, when you ask, everyone is your mentor, yes, in different aspects of life. So I have to subject this patient to AI, and for sure it's going to print out. And this tooth is through, it's just pulling through the Schneiderian membrane into the sinus. So I have to be careful not to go into the sinus. So the patient understood that we need to retreat. And then I was able to obturate this tooth and also show the patient AI after obturation that we are not short, but we are just at the apex. If there's small little bioceramic sealer extruded, it's resorbable. Do not worry. Just get your catapacha within the length. And lastly, this is another case, of course. These images were sent by Max Ray. Again, I'm not advertising. I just acknowledge who gave me the image. So this one, I asked Dr. Pondo, do you have any CBCT with a file broken? So I'm able to show the patient, and there is a lesion there with resorption, and with AI, there's an instrument which I removed, and the patient doesn't know there's a lesion here. But when I subject this patient to AI technology at the moment, the patient can appreciate that truly we have two lesions. I tell them one is bigger, another one is smaller. Even though you are not in pain, we need to do something. Otherwise, there'll be a lesion, and then it'll lead to some complications. This is lastly another case, as I'm winding up, referred to me. These files can manage a ledge. My colleague sent me this X-ray pre-op that he could get the mesiolingual canal, but mesiobuccal, he got stuck. So this is the canal he got. Mesiolingually, went through, but mesiobuccal was hitting a stop. This happens if you don't have matencytic files. They keep stretching, poking the area, creating what we call ledges, and then the file can transport. So I pre-carved, so I showed the patient we need to do retreatment with AI technology, and then after that, I was able to obturate this in one visit. What did I do? I got the matencytic files, pre-bent them, insert into the canal without rotating. Pre-bend the file, insert without rotating until you get a catch. The moment you get a catch, you are here, you are coming back. If you don't get a catch, you are on the opposite side. So you have a catch, the file is pre-bent without rotating, and then when you get a catch, you start controlling it by tactile sensation, then you are done. So finally, we have a file that can manage MB2. This file is the purple file, so you are able to manage the MB2, and even in severely curved canals, as I said, we can pre-curve the file, and then you'll be able to manage the MB2. This is a 2.7. Look at the distobuccal root. It's curving, and you cannot see the tip because of superimposition with the wisdom tooth, number 2.8. So if you rely on files, you may miss the apex. But if you rely on the apex locator, then you should be able to have this. So I was able to manage this one, pre-carving the files. Patients who have no mouth opening, how do you access the sevens? You have to go near the throat and then come back. If you don't have matencytic files, you can't pre-carve. They will straighten. Then you'll create ledge, then you'll stop. So you pre-carve the file. The way I've done like this, insert it without rotation. And then whenever you have a catch, it's called controlled tactile activation, CTA in endodontics. CTA is controlled tactile activation, and then you are able to clean the root canal without any problem. So I was able to clean. This patient was referred to me for the first case, fresh case, but patient can't open. Those were instructions. So I used Martin-side file, go, catch, and then operate. Then I was able to do results. So finally, our hands-on course this afternoon, we are going to direct it on root canal instruments that can shape and have maximum contact with the root canal. And we will also learn how to be safe. Many of you have moved to rotary, but are afraid at the same time to do endo because the file will break. So I'll show you how to perform safe endo without any problems. And then we will also optimize the success in endo. Currently, my success rate, by God's grace, last year, 2024, was around 95% success. I went through my books from January 2024 all the way to December. How many of my cases have come back and I've extracted? Or I got a call from my colleague who referred that the root canal failed. There were around 7 cases. So I calculated and I was at 95%. This year, as of this month, I am at 98.7%. I'm trying to minimize to catch up with my professor in Tokyo. Dr. Terawuchi's success rate is 99.8. He does single visits, so that's my benchmark. But for him, he saw Gadapacha 10 years ago. He told me. He saw Gadapacha 10 years ago. He operates with MTA, and he does all cases with single visits. Because his waiting period is 10 months, so he told me if I do 2 visits, my waiting period will be 20 months. And I'm trying to catch up with him. I told him, okay, I select cases for MTA. Others, I just do Gadapacha with bioceramic sealer. So by October, I am at 98.5. So hopefully I'll catch up with him when I introduce fully MTA obturation. Otherwise, thank you very much. And you can adopt these files and improve contact with the root canal, and then you'll be able to shape and preserve the dentine, preserve the tooth so that the prosthodontist can have somewhere to anchor the crown. Otherwise, thank you very much and welcome to All Malaika Trust. Doctor, I'm sorry, maybe I've got it. Oh, 1 minute for questions. Just on time, Dr. Muli, have I done well?
Thank you, Dr. Simiyu, for an excellent presentation.
Yeah, thank you. Thank you.
We'll take a few questions from the audience.
Okay, thank you, Dr. Simiyu, for the nice presentation.
Thank you.
You know, I was a bit scared when you said you have pedo files. I pinched myself, then I said pediatric files.
Okay, yeah.
My question is about apical patency. You get some canals that even when you go with file 6 and even you don't get apical patency. So in that case, do you actually have to watchwind the file until it goes beyond the apex, or you should just be happy if there is especially no periapical radiolucency? Thank you.
Okay, so that means you have a sclerosed canal. Oh, by the way, what I did mention that you have to do what you continuous chelation, what Dr. Denia likes, continuous chelate, okay, with his nice accent. So you pour sodium hypochlorite, no, EDTA, the solvent, in the canal and use these files in pecking motion, watch winding motion. This canal is sclerosed. Sometimes when it's not opening up, as you said, I increase the temperature of the EDTA. So I have this heating device, I heat directly, I see bubbles boiling. When I go back, and it must be size 6 file, 21 millimeter. I told you stock, shorter, long file. 21 millimeter, your fulcrum, your handle should be near the tip of the file. Never manage a sclerosed or curved canal with a longer file. Your hand is far away from the tip. So with warm EDTA, I'm able. But your question, if I cannot manage, it's not just going away, then I send for CBCT. Do we have any signs of radiolucency? If 0, I pack and obturate at that level. That sclerosis is a way of the body managing its infection, hardening. So if it hardened before bacteria went to the apex, for sure, there'll be nothing. However, I tell the patient, if you have symptoms later, what will I do? I'll open the gum and remove that segment that I didn't clean, episectomy. The tooth will remain. Do not extract. Okay, next. There's a question, Dr. Mrali. Yeah.
Thank you, Dr. Benjamin, for your presentation.
Yeah.
I'm right here. I wanted to ask about ultrasonic activation.
Yes.
Is it, you haven't mentioned it in your protocol of treatment. Is it something that is overrated? Does it work?
It works. That's called 3D irrigation. I told you we don't clean 40% of the root canals. Our files only contact 60. So the solutions activated will reach the 40%. Yes. I did mention because of time, I didn't want to go into irrigation in endodontics, but that's called 3D irrigation. Please do it. It's like taking your baby or child to a shower, and then you open the water tap and then tell them, okay, stand, I'm going to shower you. And just stay like that. So water rolls over, the soap is applied, and then they get out. You haven't lifted the armpits and everywhere. So we are clean. 40% hasn't been cleaned. That's the anatomically directed endodontics we are talking about. This part is cleaned differently, this part differently, this part differently. Yes.
That's the same question I wanted to ask.
Okay, yes, Dr. Mwangi. Yeah.
Thanks, Doc. That was a perfect combination of knowledge and humor. Well done.
Thank you.
The question I have, and you said because of time you don't want to touch on it, but what's your current protocol with irrigation? What do you use and how do you finish?
Sorry, come again, Doc?
Your current protocol when you irrigate, what are you using as your irrigants and how do you finish the root canal?
Oh, the final protocol for irrigation, hypochlorite. And when I'm finished with Mastercon, good question, I use conch hypo. When I learned this from the Philippines, from endodontists in the US, diluted during PMP, but at the time of removing smear layer, just drop conch hypo. And then you do what? Activate it. And then after that, wash it out with saline, and then it has dissolved the soft tissues. The next solution after the saline is EDTA to remove the hard tissues. And then after EDTA, wash away all the solutions from the canal to prevent interaction with the saline before obturation. So that's the protocol. And to modify, please just have conch at the end. You are aiming at killing bacteria instantly. Just be sure you don't extrude it. Just go irrigate, activate it. You have amazing results. No bacteria will survive if you have done BMP. The canal is open and you target the bacteria at the apex, the biofilm at the apex, subjecting it with bombardment of conch hypo. You are going to have excellent results.
Thank you, Dr. Simiyu. A warm round of applause for Dr. Simiyu.
Thank you.